So welcome to the webinar, and thank you so much for everybody's amazingly positive comments and thanks for the support that we're trying to give you. We genuinely are trying to help. And tonight is how to consult well and how to consult well enough to pass the RCA. I'm going to give you a very specific model that I've used, and I've used very successfully, and some of you may not like it and some of you may want to do something else. We're only a few weeks away to the exam, and so some of you might need to make some small changes to your last couple of weeks recordings, and some of you will be doing this already, and some of you will decide it's not for you, and that's absolutely fine. You know, don't forget to come into the RCA community to discuss this sort of stuff. We've had lots of really useful, good questions this week. I think the first thing to say is that generally all of the stuff about the mandatory criteria was covered in the last webinar. And if you didn't come on to our last webinar, don't worry, it's on our YouTube channel. Which you can just just go to the 14 Fish YouTube channel. It's up there and it's been edited. So just to briefly go over the cases and cases to advise to candidates, the advice to candidates is don't use the simplistic consultations where there's a little challenge. I'm going to show you that table again that I've shown 3 times before, but just to go back through that again, I think the more I say it, the better. Just remember that even complex patients sometimes consult with simple problems, and it's the consultation that needs to be complex, not the patient. In the CSA examiners set the standard. So if you have a relatively low challenge case, let's say for example an eczema or a mild asthma, there may be some fairly significant psychosocial element that will add a challenge that will bring you up to licensing standard. Whereas in the RCA, you're submitting the standard. And so if you submit okay cases that you do reasonably well in, but there isn't the challenge that we would expect for a UK general practitioner, you're not going to get enough marks. So think to yourself, who in the practice normally does this? And if it's a mild skin thing or a sore throat or a pill check, it might well be that that would be done by your practice nurse, and so therefore not the standard we're looking for. So as of this afternoon, I don't know if some of you saw it, but the RCGP put out a statement, so at about lunchtime-ish, and what they've said, it's a bit more expanded than this, but what they're saying is while the mandatory requirements remain in place, we recognise that there might be some challenges in meeting these, and we will endeavour to take these into account when marking. And so what they're trying to say to you is that they're going to give you a bit of latitude. I personally would try and fulfill the criteria as well as you can, but if you're getting close to the deadline, you know, there may be a bit of latitude. But I think giving out statements like that is just a bit confusing, and as a result, then we all think, oh, well, maybe we can get away with more than we can. So I would go for the mandatory criteria. As I say, they're in the first webinar. This was the table I keep talking about, and across the top there you see complicating factors. So this is describing a consultation being made up of 2 big elements. So you've got the complicating factors. So what is going on in this person's life? What's their expectations, their beliefs? You know, what's their social situation? Is there a hidden agenda? And on the other side is perhaps a bit more simple to understand is the level of challenge. So your low challenge ones at the bottom are things like mild eczema, earwax. We went through all that last time. Moderate challenge and then high challenge, and in fact some high challenge with multiple factors that make it more complicated are probably too complicated for the RCA, and you're not going to get them done in 10 minutes. So why do candidates fail the exam? There's a lovely saying that every complex problem has a simple solution. The only problem with that solution is it's wrong. And that's absolutely right here. So there isn't one reason why candidates fail. There are a number of different reasons. But here's a list that I put together. Quite often a poor choice of cases. And so candidates who would have passed with a different selection of cases actually fail. And so you've got to start to understand what the examiners are looking for. And that's what you'll get through the webinars, and that's what you'll definitely get on the RCA package. I've talked briefly about insufficient evidence for independent UK practice. And equally, it's important to remember that every consultation, no matter what it is, if somebody's coming to get a result of an X-ray and it shows something significant, a tumour, whatever, then you would tend to start at the clinical management stage. So you will tend to miss out the data gathering. I don't know, I put DB, it should be DG. So data gathering, interpersonal skills, clinical management. So you've got to think about your consultation model needs to score in each of those domains, and you have to spend a reasonable amount of time doing each section, otherwise you're not going to score well. Often candidates don't have a structure to the consultation, and so they haven't really gathered that in general practice you've got 10 minutes, and being a consultant general practitioner, it's the mastery of that 10-minute consultation. So the consultation in the hospital is much more structured, but in general practice it tends to seem more of a chat, but it needs to have a structure to it, and I'll talk about that in a minute. You've spent most of your time in hospital medicine, and so you will tend to have quite a doctor-centered, rigid consulting style, which will be based on what you've been taught in hospital. And why shouldn't you be like that? The problem is, it's a very different thing being a GP, and I'm going to talk a bit about that in a minute. It's a very different thing being a GP, and so you need to negotiate through your 10 minutes in a very different way. Often, doctors who fail feel that they need to adopt that old hierarchical doctor structure, so the doctor at the top, and they fail to involve the patient. So I'm going to tell you what I'm going to do. And so that they feel that, it's their job to sort of take responsibility and act in a parental way. So they often don't listen and lack empathy. They're often unable to see and discover the issues. They have sometimes poor clinical knowledge. And sometimes, since we've been going on with the RCA, they have poor technical quality, which you really shouldn't have recording through the 14 Fish platform, as long as you've got a stable and reasonable internet connection in your workplace. So let's go in a bit more. This, as I say, I'm really sorry if this feels a bit basic, but it's really key. So why do patients come into UK general practice? And if you speak to politicians, most of them assume that patients initiate a consultation with a GP because of a new set of symptoms that indicate an underlying disease. And your hospital training, because the people who you see in hospital have been sieved usually by a general practitioner, the people that they see in hospital almost always do have a disease. But 95% of all of the patients seen in the NHS are seen in general practice and sieved out in general practice. So most of them won't get on to this secondary care. And so the sort of patients that you're seeing in secondary care are very different from the ones in general practice. But in the community, lots of people have symptoms regularly and don't go to the doctor, and the symptoms go away. And you probably get symptoms. Some studies say that 80% of us have some sort of symptom on a weekly basis. And obviously you don't all go to the GP. As medical students, you talked about the clinical iceberg, didn't you? So that really only the top bit of the iceberg came in to come and see clinicians and came in to be looked at. And so there's this great big area of people with symptoms that never get seen. So in fact, in general practice, we rarely see disease. We see illness, behavior and symptoms. And I'm going to talk about the numbers of cancers that we see on a yearly basis, because your big fear is that whatever comes through the door is going to be something serious. So how do we deal with our symptoms, and what's it called? Well, the way that we deal with our symptoms is called illness behavior, and this is affected and influenced by a number of things. I've had this list going for a few years now, and it's interesting that family and friends are slipping further down, and now Google is number one. 10 years ago, nobody used the internet to diagnose themselves, but now it's really, really quite common. One of the doctors gave a Christmas present to the other doctors in our practice a few years ago, and it said, "Don't forget, don't misinterpret your Google search, or don't misunderstand your Google search for my medical degree," and it caused huge offence amongst the patients, all of whom were using Google. So family, community and friends, culture, previous experience. So depending on what's happened before, if you fell over and hurt your leg and got up and you were absolutely fine, the chances are if you do it again, you'll think you're going to be fine. If you fall over and break your leg, you're going to assume that you've broken your leg. If you get chest pain and it's a heart attack, the next time you get chest pain, you're going to think that it's a heart attack. There are quite a lot of social triggers, and that's pressures from others, particularly if it's interfering your work-life balance or stopping you go to work. The patient's personality, there is a level of resilience, and more resilient people often work in more resilient jobs and so get less traumatized by it. But so the patient's personality is important, and their overall levels of stress. The whole country and the whole world's level of stress at the moment is higher than it usually is. But all of those feed in quite a complex algorithm to make the patient decide whether or not they ought to come and seek medical advice. So in the UK, I've put nobody, there is the odd person and you probably know them, but in the UK, nobody goes to the doctor with just a symptom. They go with an idea about the symptom, a concern about the symptom, and an expectation of what you're going to do as the doctor based on their theory. So if you imagine the patient, when they first comes in with this invisible bubble around their head, and in it is their model or their idea. And it may be completely mad. It may be something we wouldn't even think of. It may be fairly sensible. I mean, some people, are very good at researching their medical problems, but other people aren't. So if we don't unravel this illness behaviour, then the consultation will fail. And various, famous people writing about the consultation, Byrne, for example, talked about dysfunctional consultations, and that's what it means. Really, we should both start as two dots at the beginning of the consultation, and then we should go through the consultation and still end up two dots together so that we've been speaking the same language and understanding each other all the way through. That often doesn't happen. So how are we going to unravel illness behaviour in 10 minutes? So the hospital consultant, the consultation model is all about symptoms of disease. And so what you are after is a disease-based model that is based around diagnosis. So you do a history, examination, investigation, make a diagnosis, come up with a management plan, and then do a follow-up. And hospital doctors, if the patient doesn't fit the model, and every now and then someone with a functional illness, by which I mean they've got symptoms but no underlying disease, functional illness people, if you give them the hospital consultants, often end up having multiple operations, multiple treatments, and end up in a lot worse place than they were when they started. So you need to stop focusing on the diagnosis and analyse their illness behaviour. And I know that you're going to find this difficult, even at this stage in your training. Some of my senior trainees have said to me at the end of a surgery, I had a really good surgery. I had a patient with hypertension and Parkinson's disease, an acute admission with appendicitis. And I'm like, God, you've completely missed the point. Because the point is to unravel that illness behaviour and get to the end where you come to an agreement and realise there isn't a disease. So try and stop focusing on the diagnosis and analyse behaviour. My trainer was a fascinating man. I loved him dearly and taught me a huge amount about general practice. And he always used to say, the best thing about being a GP is you never know what's coming through the door. And the worst thing about being a GP is you never know what's coming through the door. And he was absolutely right. But certainly as a trainee, everybody who comes in with a neck lump, you assume they've got a thyroid cancer. Everybody with a cough, you assume they've got lung cancer. But just by way of reassurance, just to make you relax a bit, try and forget about the diseases and try and think about the behaviour, then it's only we only get 8 new cases per year per 2,000 patients. So a full-time doctor does 8 sessions and will probably do 20 to 25,000 consultations in a year. Will only see 8 new cases of cancer. Only one of them per 6 months will be lung, 1 per 12 months will be breast, and colorectal and skin together is only 1 per 18 months. I mentioned at the beginning that you see somebody with a lump around their thyroid, you assume it's cancer. You're probably only going to see 1 thyroid cancer in the whole of your career. So you need to create a structure. I talked about good candidates, or should I say bad candidates, not having a structure and failing. And I'm going to talk about good candidates having a clear structure to get through. You need various waypoints. You need various little barriers to jump over. And once you've gone over those little barriers, you don't want to go back because you're wasting time. You've only got 10 minutes. You've got to score in data gathering, clinical management, interpersonal skills. So you've got to know what you're doing and take it in bite-sized chunks. So you do a chunk at a time. So I divide the consultation up into 3 sections. And so section 1 is all about finding out about the problem. And a consultation is like a story or a joke. There's got to be a beginning, a middle, and an end. And I see failing candidates in the exam regularly, and they just seem to be going 2 steps forward and then 1 back, and then they repeat what they've asked before, and then they start talking about management right at the beginning. You know, there is a structure, and if you're talking about management, it should be at the end. So at the beginning, we're finding out about the problem, and I think you should take about 5 minutes. You'll all have a favourite greeting. How can I help today? What can I do for you today? I saw somebody the other day say, and what are we going to achieve in the next 10 minutes? Which isn't the way that I would do it, but it worked quite well. Try it if you haven't tried it, but not on your last video attempt of the dart. Have a go tomorrow. So you do your greeting, and then you've got to understand about the illness behaviour. And the way that I would encourage you to do it is to start with psychosocial. Some of you aren't going to like that, and for that I'm sorry. But just like you often haven't met these patients, and I'd encourage you to see acute patients for the exam because you've got more to find out about. You've not asked them all about their family situation before. So you need to ask about their psychosocial setup. And just like any conversation, if you go up to somebody that you don't know and start by going, how are you? And what's your life about? What's your job? All that sort of stuff. It creates empathy. It makes you work together. And it relaxes the patient. So if you then go from there into ideas, concerns and expectations, what did you think was going on? Did you have any particular concerns? What was your worst fear? What were you hoping I was going to do today? I often say lots of people have sat around and thought about the problem that they're presenting with. And what were you hoping for? What did you think I was going to do? If you say that sort of in a way without any conviction, then the patients think you're rubbish and think you're mad. So you've got to sell it. So if you're going to say to somebody, tell me about who's around. I mean, particularly psychosocially, so I am jumping back now, but psychosocially, so in that first step of understanding illness behavior, psychosocially, everybody has got a psychosocial element during a pandemic. There are loads of people with health anxiety. There are loads of people with depression. There are loads of people who are actually enjoying it. I was on the phone to the bank today, and the admin clerk at the end of the phone said she loves it. She's being at home. She can go out on a bike and do a running and stuff in the morning. And so it may be a positive, but there is a psychosocial element to everybody. So ask about it. Particularly in the elderly, I want to hear you asking about who's in their support bubble, who's doing their shopping, who's at home with them, and in the under 16s, I want to hear you asking about what's happening at school, how's that affected them? Have they enjoyed schooling at home? Do they prefer to go to school? Ideas, concerns and expectations, and then I'll let you on to the bit that you will love, which is the history taking, so finding out about the symptoms and then excluding serious illness by asking about the red flags. This whole presentation is in much more detail on the RCA package, but I'm going to try and keep it down to 25 minutes tonight, and then that will leave plenty of time for questions, which is what your feedback was last time. Section 2, this is the middle bit, and this is when you're thinking about doing an examination, because this is all feeding into your history, isn't it? The examination is part of data gathering. So this is, I'm coming up with a theory before I share it with you, and before I look at what your theory was, and we discuss that. So you may want to do an examination, and there's lots that you can do on audio and video, and I'm going to talk about it. So next week, so this time next week, I'm going to do a top tips and how to negotiate the best consultation in the next 2 weeks before the final submission. So I'm going to talk about that next week. Lots of patients have thermometers, blood pressure machines, blood sugar machines, SATS monitors, lots of good stuff, and you can get them to do that. Don't forget the rules on patient exposure. I covered that in detail last week, so have a look at last week's webinar. And you may want to bring the patient into the surgery, in which case, when you say at the end of the consultation, I'm going to bring you into the surgery, and this is what I would like you to expect. I'm going to examine your chest, listening for crackles, do your temperature, do your blood pressure and pulse, do your SATs, and explain to them that you're looking for signs of infection or acute exacerbation of COPD, or you're just confirming your diagnosis, and with that you'll make a decision as to whether to up their COPD treatment or whether to actually give them a completely different treatment with some antibiotics, or even actually admit them if their SATs are particularly low. So we're now on to section 3. So this is it's only 3 sections, and if you've got it clear in your mind, don't go backwards and forwards. So do section 1, section 2, and then into section 3. And clinical management is the commonest cause of failure in the UK now. That's partly because people don't get there, so they don't spend enough time. And I think it's a minimum of 2 minutes, but probably 3 or even 4. So you need to have a stopwatch in your room. You need to be watching the time, and you need to be practicing so that you're getting round to the explanation at the end. The explanation, clinical management, is 3 points, just like the others. So you're making a working diagnosis, and that may not be a word like sciatica. It might be you came in and you thought you had a brain tumour, and actually having listened to you and heard your symptoms, I'm pretty sure it isn't. So you then need to explain it to the patient, bearing in mind what they've told you in their theory. So is there something you can tie in about their psychosocial? Is there something that you can tie in about what they thought it was, what they were hoping for? And then you're agreeing a plan of action by discussing it with the patient. So I often say to people, you've got this, and I would do this. However, there are some other options if you'd like to do them. I don't think you should be listing 5 options randomly. You know, you've got a bad knee, so we could do nothing and wait and see, give you Nurofen, do an x-ray, send you to physio, or maybe send you to an orthopedic surgeon. That's not options, that's just sort of random management plans. And so I think you should be giving them a bit of guidance. You should be sort of saying, you know, you came in wanting antibiotics for your sore throat, and actually we try not to give antibiotics. We've used a scoring system on you, which would mean that your chance of it being bacterial is low, and there are some side effects to antibiotics. But you may then get round to saying, you know, they say, well, last time I had a quinsy and I really would like some antibiotics, and you may negotiate round. That's good general practice. And then arranging a follow-up to check that the action plan is working. And depending what that is, you may say about an ill child, I better give you a call this afternoon. You may say about somebody with some back pain and sciatica, you know, if it's not improving in 3 or 4 weeks, then I want to see you again. So your follow-up and your safety netting needs to be appropriate for the case. So section 1 and 2, which is your opening gambit, taking the history, excluding serious illness, is where you get your 3 points in data gathering. Your clinical management is section 3, and then interpersonal skills come all the way through. So why do candidates pass? They adopt a good consulting structure early in training, and so it becomes so natural. You know, in the RCA, you've almost got even more to do than you did in the CSA, because the patients are a bit unpredictable. You've got to be filming it appropriately. You've got the computer screen, you're in your surgery, so it's not like there aren't other distractions. So I understand that you're going to be distracted, but you've got to practice it every day. You're not practicing this consultation model just for the RCA. You're doing it to make your life in general practice much easier. So you need to practice, and practice all the time. Practice with your partners at home, practice with your friends at work if you can. You know, use the system, go on the system and do some mock consultations with your friends. Watch some good GP consultants. In your surgery, there will be a varying range of consultants, and there'll be some really good consultants. Which ones are popular with the patients? Which ones get the best out of the patients? Who runs to time? Have a look at them and see if you can either get them to video themselves, and you can use our 14 Fish app to video them for free, or they can actually use the system. Make sure that you get watched. There's been quite a lot of anxiety by trainers about how much of your videos they should watch. Well, they should watch your videos. They should be sitting in. They should be helping you with role play. They shouldn't be telling you which ones you should put in and which ones will pass, because that would be unfair. You know, it's up to you to decide. But they are allowed to watch your consultations. So forget every consultation that you've ever seen in a hospital training room. I always say that to irritate my good friends who are consultant colleagues. And in fact, I've got a friend who's a cardiologist. He's quite a good consultant, actually. But I would sort of wipe out that memory of diagnosis, disease-based consulting. If you are going to work in a group, and a number of people in the community have formed form groups, is I'd encourage you to have a mix. We often tend to sort of veer towards people like us. And actually, you hear phrases and sayings or watch somebody do something who is completely different to you, whether that be sort of age or sex or race, because you can then you're going to learn much more in a mixed group. So I would encourage you to do that. And I definitely encourage you to use the 14 Fish RCA package, which a number of you are on anyway. And it's reimbursed on your study leave budget in most deaneries, and some deaneries are going to buy it en masse. But we'll give you access until you pass. And if you're on here tonight and you think, well, I'm not going to actually sit my exams until the end of the year, and it might be the CSA then, although I think it's unlikely. If it is the CSA, we'll give you free access to the CSA package if it did change during that time. So if you want to use the package, get on it as soon as possible and start using it. Don't forget to keep watching all the clinical updates. So we've got a big clinical update section, and it covers a lot of the main areas of general practice. And what it will do, it talks a lot about each section, each particular topic talks about a focus history, so risk factors and things to look for, what you should be asking for, and it gives clear evidence-based new guidance management, which is what the examiners want to see. So you won't pass if you're a brilliant communicator only. You've got to manage these common medical problems well. So I've gone on a little bit more than I wanted to, so that's about 30 minutes. I really would encourage you to focus your efforts. There's been some great comments on the community. Lots of people asking relevant questions, which mean that they're getting into it. And I said last time, and I'll keep saying it, don't fight the RCA. The RCA is here at least until the summer. And if you learn how to deal with it and you consult well, you will pass. It doesn't matter who you are. So focus your efforts. We've got a number of the 14 Fish admin team here this evening, and so they're going to field your questions. I know that there'll be quite a few. So I'll end the show, and then we can get you back and get some questions from you. So I think is it Molly and Maria who are asking questions tonight? Or is it Duncan?
And myself, Mark, even slightly, you're probably Duncan. We've got some great questions actually come in, and I suspect, like most of the time, we won't be able to get through all of them, but I'm just going to start at the top for now. I'm struggling to understand MSK cases in terms of moderate and low challenge. For example, I've seen a 67-year-old man with unilateral shoulder pain and pins and needles. I did a video exam, ruled out red flags, gave pain relief and exercise with follow-up and safety net. Trainer felt that it was all okay, including examination, but has felt low challenge. Whereas I felt fitting in examination within time and doing all the MSK was challenging. What do you think?
I think that's a brilliant question, and some people are struggling to understand challenge. I think you've got to look at it like that table, and I keep showing that table because that's key. And so it's the clinical complexity on one end, and on the other end, it's the confounding factors. So let's say, for example, the guy that you described, which with no confounding factors, I would say was low challenge. But let's say, for example, his wife had recently died, or he'd been in hospital with COVID and was struggling, or he was suffering with isolation, or, if there was something in there that you could sort of tie in that just added another dimension. So I think from what you describe, you're doing well, you're consulting well, it would count as an examination case, it would count as someone over the age of 65, but you may find that because of the lack of complexity, you're looking at around 5 out of 9 rather than 9 out of 9, and it sounds like you could be an 8 or 9 candidate. So, just think about the confounding factors as well as the complexity.
Brilliant, thanks. I think Maria and I are going to tag team. So Maria, have you got a question?
Yeah, sure, thank you. So the next question is, if you're planning to bring a patient in to examine them to decide further management needed, for example, referral onwards, can this case still be used as long as explaining what the next steps are after the examination?
Yeah, the problem that, as I mentioned in my section model, so section 1, 2, and 3, what tends to happen in these consultations, when you've done the consultation on the phone and you bring them in to examine them, if you use the phone part, you often miss out in clinical management and a little bit in data gathering because of the examination. And if you use the face-to-face part, then you often lose the data gathering. So my advice, in all honesty, would be to try and do as much as you can in your initial consultation, whether it be phone or video, and use that. So, and at the end, so as you're saying, well, I need to examine you to find a diagnosis, but actually the most likely diagnoses are arthritis of the shoulder or a problem with your neck or something else. And so I'm going to examine you and I'm going to be looking for this. And if it is osteoarthritis, we'll manage it like that. And if it is your neck, we might manage it like that. And so why don't we arrange for you to come in and I'll examine you as I've explained, and then we'll take it from there. And I think that way you're going to score most points in all of those 3 domains.
That's great, thank you.
Thanks, Mark. So I'm going to go, rather than just going the early ones, sort of mix it up a bit. For examination component, if you use the mental state, is that okay? And if so, whoops, I jumped over where I was reading it from. Sorry. What do you expect us to verbalise, for example, tone of speech?
Yeah, brilliant. So really good question. Yes, if you do a mental state examination, let's say somebody was depressed, we don't expect you to do the Defeat Depression campaign screening questionnaires or anything too complex. Asking if they feel depressed is almost enough, but then sort of asking a bit about their concentration, how they're getting on at work, what's their function, how it's impacting their relationship. So I think sort of 4 or 5 good questions around there and you're going to score well. If you just said, and do you feel depressed, sort of 1 question, you're going to score less in data gathering. It would still count as an examination case because we will give you a reward for that. But why not do it? Have a look at the depression module on the clinical update, and I go through some really useful screening questions in depression that you can ask very quickly.
I've got one here that I have a recording of a patient who I offered a face-to-face examination, and what my thinking was for it and management for it if it was the said problem. They declined the examination. Would that then go against me?
Yeah, that's a really good question, actually. I think if you've described what you would examine and then offer it to them and they decline, that's fine. You'll get marked on what you vocalise. So we can only mark what we see. And I saw a case the other day where it sounded like a barn door DVT, and when they came into the practice to see one of my registrars, then it was obvious that it wasn't. And so, in the workbook, they said, oh, God, is that going to be an acute case, all that sort of stuff. And actually, because it generated an acute reaction, and it sounded like that, it didn't really matter what happened. What we're scoring is what we see. So it's a bit like a driving test. We're not scoring you driving home, we're just scoring you on the actual test itself.
Great, thank you. So there's one here which states, any advice on which curriculum topic to link conditions which can be considered to have multiple causes? For example, fibromyalgia, which has MSK symptoms, neurological symptoms such as pins and needles, or psychological symptoms such as depression and anxiety.
Personally, I would, because you're absolutely right, fibromyalgia you could link to pretty every other curriculum statement, but I would tend to do ones that you're short of, because then it just looks as if you're spreading it out a bit. I don't think that's cheating. I think that's perfectly reasonable. So I would link it to the one that seems most likely, and if there isn't a most likely one because of multiple symptoms, then link it to one that you've got fewer of.
Mark, I've got a question here. This is a question I haven't had before. Can I use consultations where I'm discussing problems with care home staff regarding one of the residents there? I've got good cases with good complexity covering psychosocial aspects, but would the consent by proxy be an issue? Because it's not the patient but the care home staff consenting.
I mean, funnily enough, in the CSA, we've written cases just like this, and we quite like third-party consultation. So yes, it's perfectly reasonable to do it, but you probably want to get your trainer to listen to it and say, I don't want you to score it, but I just want, if you were looking at this as an independent GP, so if you ask them to pretend that they're the examiner, do they think that it was obvious that you had consent from the patient or from the family or from whoever's got power of attorney to discuss it? But yes, so it's a really good question. There's no doubt it's complex, and it can make a complex consultation, but it can really score well. So don't be put off doing it. Probably get a second opinion as to whether or not it's obvious that you've gained consent.
Maria, have you got a question, or do you want me to jump in?
Yes, sorry, could you jump in on this one, please? Thank you.
Yep. How about this, Mark? It's a bit more of a general question. Can the shared management be more explained, please? And also, have you got any phrases or tips?
Yeah, so on the package, there's quite a lot of additional stuff about it. But shared management plan is when there are more than one option. So let's say, for example, a bad knee. It might be that you are fairly clear it's osteoarthritis, and it might be that they've not really tried much, and it might be that you say, well, it depends if you're a tablet taker or whether you like physical activity, because you might well find, some exercises and, some physiotherapy are the best thing for it. But on the other hand, if you're a tablet taker, and let's say, for example, I don't mind taking tablets, I would take a tablet. So sharing management is when there's a realistic choice. So some people do that and some people do that. I'm not sure I've explained that very well, but I'm just sort of saying that there is almost always do nothing or do something. So in almost every condition, and I've talked about illness behaviour, the vast majority of people will say, well, all I really wanted was some reassurance. I don't actually necessarily want any treatment. If you, it's interesting, if you questionnaire a waiting room of patients, roughly what percentage do you think are going to want a prescription? And the answer to that is about 20%. If you ask GPs, they say about 50%. And then if you go to the pharmacists, they say about 50% of people don't cash those prescriptions in. So we obviously feel, mainly because we're hospital trained, that we actually want to give the patient something. They've come in, we want to give them something. Sometimes what they want is the doctor as a drug. They just want you to give them your time and your expertise and say, having examined you, I don't think there is anything serious. So doing nothing is an option, and it might well get better by itself. But if you would like some treatment, then we could give you some tablets or some physio. So that probably makes it a bit simpler, I think. I hope so. Did that make sense, Duncan? Probably not.
I think that did. I've got, while we're on the subject of tips, I'm going to try and sort of kill two birds with one stone. Hi, thanks for the talk. I'm wondering if you have any tips or suggestions with how to deal with consultations with multiple issues, or people who go off on tangents, or avoiding the doorknob complaint, as it seems our patients group rarely present with one thing.
I mean, once again, a very interesting question, and to a certain extent, this is why I would encourage you to do quite a lot of your videos in the acute clinics where you're not seeing people who are coming in with lists. Funnily enough, on the CSA, we trialled doing multiple problems as an examination case, and they didn't work because you couldn't really mark them very well. So I would try and avoid the multiple problems if you possibly can. So persuade your trainer to let you book more acute type patients, acute on the day, and if you get a really good consultation and at minute 9, then the patient suddenly says, oh, by the way, doctor, can I talk to you about something else? You can just let it run, deal with it as well as you can, and the examiner will mark your first 10 minutes. So almost certainly just ignore that extra minute at the end. So if you do a good consultation, but the patient won't leave the room because they've got their hand on the door, don't worry about it. That's absolutely fine. As I say, once we've done what you do, you're verifying their name or whatever it is you do at your consultations. As soon as you say, and what can I do for you today, the examiner starts the clock and then stops marking at 10 minutes. So if it does, I mean, one of the consultations I looked in the exam last time was something like 25 minutes. I thought, poor guy, because they obviously went on and on and on, and that sometimes happens. But actually, the first 10 minutes was very good, so that was fine. So don't be scared of putting them in, but try and do some, on the day rather than review type patients that are likely to be a bit more demanding. I look at the list of consultations that my trainee has, particularly when they're coming up to their exam, and I know which ones are going to be problematic because they do go on, and they will come in with multiple problems. They're never really happy with what you say, and so I take them off and I deal with them and let my registrar get on with some potential recordings. So it is difficult, but as a rule, putting in cases with multiple problems where they deal with multiple problems in that 10 minutes is not a good idea.
Perfect, thank you. I have one here which asks if the two examination cases have to be different, for example, if the two are a mental health exam.
No, they can be exactly the same, and if you do them both well, you'll score high in both. They like the examiners like you to have more than not more than 2 curriculum areas the same. So if you had 2 mental health examinations, that would be your lot, but it would count as an examination. But you're effectively, each consultation is being marked by 2 examiners, and no same examiner sees you more than once. And so if you use a lot of the same phraseology and the same terms, I think that's great. It's certainly what I do. I've got some stock phrases that I use all the time, and I use my structure and I go through the sections, particularly when I'm a bit lost. So definitely don't be scared about using the same words. Don't be scared about a same examination, a similar examination. Even if you put in, let's say, 2 shoulders, or a shoulder and a back, or a shoulder and a hip, that would be absolutely fine. So I think that's fine.
Thanks, Mark. Just got one here that if I can find it, sorry, it's immediately as I was down to ask it jumped up. Of course, it's Murphy's Law, isn't it? Where's the... Yeah, you haven't got one, have you? Well, I quickly find my... Oh, I've got it. Sorry. I mean, they're all great questions, but I just really liked this one. Thanks. Very useful. Some feedback I've got from supervisor trainers are that the ICE should not be done in an obvious way, as it can make the trainee look robotic or reading out of a script. I have some anxiety that examiners may mark me down if I do ICE a very formal and obvious way. Also, with regards to empathy, I've been advised not to use generic phrases such as "I'm sorry to hear that."
Yeah, It's a very thin line between sounding robotic and being empathetic. But one of the keys is to think to yourself, I'm gonna behave like I'm talking to a friend of mine who's got a medical problem. So I'm going to try and be as relaxed and as empathetic and use the sort of phrases that I would use if I was, sat on a park bench with my best mate and he was telling me a problem or he was telling me he was upset. And I would react sympathetically. And sometimes, the right phrases come out and sometimes they don't. And sometimes when you say the wrong phrase or you say something that sounds insensitive, you go, I'm really sorry, that sounded insensitive. That's the more realistic, the more from your heart, the more personality you give, the better. As far as ICE is concerned, you really ought to be asking ICE. You ought to find some words that seem normal to you or seem to come out of your mouth easily. I saw a consultation the other day where this very smiley, sort of fluent young woman was consulting. And she said, did you have any particular ideas? And were there things that you were concerned about? Had you researched it? Had you Googled it? And it sounded really natural, even though she said ideas, concerns, and expectations. So a bit like I said in my talk earlier, it's got to sound fluent and it's got to sound as if you do it every day. It's got to sound as if you believe it. So, definitely put it in, but start practicing it. So that it doesn't sound robotic. Ask people at home, use it to ask them what they're like for dinner, ask them about what they've been doing in the day, but put it into a consultation format and you'll find that there are words that suit you. I mean, I love the expression, what's your worst fear? Have you been looking this up? What would you really worry about? What would be at the back of your mind? Lots of people have things that they worry about. So I would play with some words. We could do some on the community, have a look at some words. And you pick the one that works for you with your personality, the way you look, the way you behave. As you've seen tonight, I've flapped my arms around quite a lot. So I'm quite loud and quite noisy. And so what I say might be different to what you say if you have a different style. So don't be scared of it. Definitely do it. I would prefer it robotically than not at all. But if you practice it, you lose that sort of stilted robot-like nature. So do keep trying it. It really is a good thing to do.
Thanks, Mark. I have one here regarding third-party consultation, which asks, do we have to verbalise the consent provided by patient to the partner at the beginning of the consultation if the patient felt too poorly to speak on the phone and all consultation was completed by the wife, although the patient has given consent to speak to the wife?
Yeah, I mean, as I said before, third-party consultations can be really good and score really well, but they are quite hard. They often do run on because often a third party almost has more concern for the person than they have for themselves, and so they often ask lots and lots of questions. But I think I would, just to be absolutely sure, I would probably like at the beginning to just get so if you just clarify who the person is, clarify who the patient is, and then clarify that you've got consent or that you've seen consent or you've seen permission or you've seen a release letter. In fact, if you did that all in the first sort of 30, 40 seconds, then what you would find is that the examiner doesn't start until you start saying, oh, well, that's great, and how can I help today? And so even if it might take a bit longer than normal, even say a minute, then that time wouldn't be wasted because you'd put the examiner at their ease. They would know that you've got the right consent, and then they start the consultation from and how can I help today? So don't be put off. They are quite hard. I've tried to do a couple of role play videos on third-party consultations. They were quite difficult, but if you can do it, great.
And there are a few questions on consent, and we're trying to keep going, but we probably haven't got time to answer all the questions left. But would you agree, Mark? I'd say, we've got a help page on this on our website. The college website, actually, for the RCA consent is actually helpful, I think.
Yes, I mean, it's very clear on our website, and Phil put a link up on the community the other day. So definitely have a go at it, but hopefully we've made it clear because there is some confusion. The basic rules are that on 14 fish, the examiners don't worry about consent because it's done at the beginning, at the end. You will be cued at the end because it's considered good practice for you to, at the end of the consultation, to get consent. It doesn't need to be in the 10 minutes, but it's considered good form to say, at the end of the consultation, you'll get another message to make sure that you were happy. If they tick the you're happy with the consultation with us on 14 Fish, then you can submit it anyway, even if you then do it off camera. If you're submitting your own consultations and uploading them, it's a bit more complicated because you have to demonstrate the paperwork or your educational supervisor. But have a look on Phil's link that he did the other day, or in fact we can put the link back on there this evening and you can all have a look.
Are you okay for to keep going, Mark?
Yeah. Should we do a couple more and then we'll talk a little bit about what we're doing next week if anybody wants to come.
Perfect. I think this is it. This is an interesting question and very genuine. I feel that I sometimes don't pronounce words the right way. I'm working on these, but does these things count towards a fail or a pass?
No, not at all. So we're not marking the English language at all. So we all have different accents. Depending which part of the country you're from, that doesn't matter. The only time it would be a problem is if the patient doesn't understand what you're saying. So if the consultation is affected by them not understanding, so because we're marking your communication and your consultation skills, and if the patient is getting the wrong idea because they're misunderstanding, then you might be marked down. But do work on it. I've had a couple of registrars that have struggled in this way, and one of the best things was us talking and just verbalizing and vocalizing ways of saying things. So don't feel you're going to have prejudice against you, but if it affects the consultation, you may need to work out simpler ways, because some of the patients just don't get it. I mean, they don't get what I say sometimes. But no, don't be put off by that. But do a bit of work on it and pick consultations where it's clear that the patient understands.
Perfect, thank you. Sorry, did you have a question, Duncan?
Sorry, carry on. Sorry.
Is it okay to have all telephone consultations, as I'm struggling to get good videos or face-to-face consults?
Yeah, that's a very reasonable question. And yes, quite a number of people. In fact, telephone was by far the most popular in the last set of exams. So if you put in all telephone, that's absolutely fine. Is there a difference between telephone, video and face-to-face as far as people's marks are concerned? Absolutely not. Obviously the video, to a certain extent, you can do some examination stuff quite cleverly. But no, all telephone, absolutely fine. I personally would try and put a mix of telephone and video, and I probably would avoid face-to-face because it's quite, in PPE and everything, it's all a bit of a nightmare. And so I would probably just do telephone and video, and depending, which you prefer, then put as much as you like of either. So yeah, really good luck with that. And we've got a number of candidates who are shielding, and so they can only really do telephone. Obviously, with good internet connection, they do video, but particularly in an elderly area where they don't have mobile phones, then they'll just do telephone. So absolutely fine, and don't worry about not getting a good enough score. We wouldn't know that you've done all telephone anyway as an individual examiner. But good question, thank you.
Thanks, Mark. Time for one more?
Yeah, one more.
Any case needing a 2-week referral, would that be complex or need a confounding factor?
Yeah, so a 2-week referral would be considered an acute case, and it might be that it's acute case in an over 65, so that would be an older person as well, so you could get 2 mandatory criteria at the same time. It doesn't necessarily, it always helps to have a bit of a confounding factor, some sort of anxiety about going to hospital. On a 2-week wait, by and large, the sort of people who are going on a 2-week wait are a bit older. So it's highly likely that they're in a relationship, and just simply asking, who's at home with you, and when you consulted the doctor, what did your partner think was going on? What were they expecting was going to happen? And so, just getting that bit at the beginning, so the beginning of your consultation, getting that bit that where you're finding about their social support, who's in their support network. That's quite a good question. So who's around them, and how are they going to react? How are we going to communicate with them? So a 2-week wait, there is going to be a confounding factor. It's just getting in the habit of unveiling it.
Can I be cheeky and just slip one more in? Because actually I think this covers a few concerns that people have got. So it's someone who's done an examination, so I'll read it out actually. I've done an urgent face-to-face painless lymphadenopathy with night sweats case, examined the cervical lymph nodes and examined the abdomen behind the curtain, but I forgot to verbalise my findings when doing that in an exam manner. And can I consider this tick box both the exam and the urgent place if my examination was clear on the video? So I guess it's sort of, the reason I thought this might apply to others is, you've done lots of other bits well, but you've missed out. You think back and kicking yourself, you've missed one thing.
And so we genuinely, I was responsible for examiner training, and so it's really important that we emphasise we're not looking for perfection. You should get 9 points in your consultation, so 9 out of 9. If you negotiate your way sensibly through the consultation, you might miss a few bits here and there. As long as they're not vital, then you can still score really well. So it's the overall feel of the consultation that you're being marked on, and not the fact you miss 1 point. You might forget, if somebody smokes, or you might forget an alcohol history and someone with cardiovascular disease. Yes, that seems like a big deal, but you could probably still get 8 or 9 out of 9 if you did the rest really well. So there isn't such a thing as blackballing.
Thank you. Shall we leave it there?
Yeah, no, there we go. That's 8 o'clock. I did promise we'd only be an hour. So this time next week, I'm going to do how to get the best out of the last 2 weeks before your submission. I've invited along a trainee that's just recently passed very well to get their contribution. But I'll do about 20 minutes of some top tips and things to look out for, and sort of cases that might do really well, and then we'll have a discussion, and we'll get Lucas's opinion as to his views, and it might be slightly different from me, but I think it would be really good to see. Anyway, it was lovely to see you all, although I haven't particularly seen you. It's lovely that you came. Thanks very much for your time, and see you next week. But do keep doing it. You can do it. And just really good luck.